I'm Jonas Schwartz. I'm in the Department of OBGYN, and I am a complex family planning specialist, so I do primarily abortion and contraception. And I'm also the medical director of our family planning clinic, just so you know I have some street cred. It's always fun to give this lecture. And I was going to start by offering you the opportunity to choose what you wanted to learn. You know, abortion is an unusual topic in that it has many social and political and medical aspects. And in the lecture, we cover many of those parts. And so we could focus really in on what you definitely wanted to get out of today. However, given that we have a lunchtime thing where I think I'm primarily the person who you get to ask questions of, you can come there if you want, if you don't get your direct questions answered. It's been quite an abortion several weeks at Duke. Last week we had Diana Foster Green, who's the PI of the Turnaway study, and her sister, who wrote a play based on that. And one of your colleagues, I saw her here, was a star in that play, which was fantastic. Did anybody go? It was terrific. And I'm happy that only one of you is there because I'm going to steal something from that play, and this way it'll be fresh for you. So I am an Nexplanon trainer for Organon, actually. But the most important disclosure I have is that I know and love people who have had an abortion, and most of you probably do too. Actually, well, all of you do. You just may not know that they had the abortion. We will talk about the epidemiology of induced abortion, the changing legal landscape of abortion, the methods used for induced abortion, and the risks and benefits of induced abortion. Now, this may seem contrary to what I said when I asked what questions you had and went into all of the various aspects of abortion. However, I would say that all of those components are really part of the science of what we know about abortion. It just happens to cut across so many parts of our lives. However, what we're going to talk about today is the science, right? So I'm not intending to, well, I will not be being controversial. I'm just giving you the science. It's important to be deliberate in the way that we talk about abortion. Dr. Howell just told me that she gave you the definition of pregnancy, which is excellent and important foundational concept. People use many different words when they talk about abortion and when they describe abortion. The medical definition of abortion is the removal of a fetus or embryo from the uterus before the stage of viability. The problem with using euphemisms for abortion, other than maybe induced abortion, which is just an extra word, not a euphemism, is that we stigmatize abortion then for our patients and each other. And it is a medical procedure, right? It is something that happened that we do medically, and so we need to talk about it in a precise way, and I would encourage you to do so. I try to do so with my patients. Now, you will hear in your clinical opportunities for teaching that it's important to say what the patient says, to use the words that the patient says. And there are times when a patient might use different words, and I might modify based on that. But otherwise, I'm not scared to use the word abortion, because I'm not trying to stigmatize a patient for the abortion that they're having. I also have elective highlighted here. So there has been a movement in the family planning community for a number of years to discourage us from using the term elective abortion. People often describe what I would say are socially indicated abortions as elective. So those that don't have some sort of medical or genetic indication, a medical indication for the person experiencing pregnancy or a genetic indication for the fetus. And the reason that terminology is problematic is that it creates this hierarchy, as though one abortion is more deserving than the other abortion, or one abortion has more merit than the other type of abortion. And so I try very hard not to use the word elective when I say abortion. I'm not perfect. At one point I was sitting next to someone who I had just met and was a mentor, and I got to give a talk with her, and I was sitting next to her at dinner, and it was, she's like an older person in the field. It was such a thrill, and I said elective abortion, and boy, did she correct me. But I tried. The other reason that elective was shown to be a problem was during the pandemic, many states canceled elective procedures, and they put abortion right in there with those elective procedures and just stopped them And we know that oftentimes those abortions are time sensitive, if nothing else. And so I would say it's inaccurate to describe them as elective. So almost half of pregnancies in the United States are unintended, and 1 in 5 pregnancies end in abortion. This is the part where I'm going to steal from the Turn Away play. So I'm not going to ask you to raise your hands, but if you think to yourself about when unintended pregnancy may happen, right? Like what is required for an unintended pregnancy to happen? We know that about half of people who have an abortion were using contraception in the month when they got pregnant. So think to yourself, if you've ever had sex in a time when you were not intending to get pregnant, but did not use contraception in a way that would have 100% prevented pregnancy. No, I mean, abstinence is the only 100% prevention of pregnancy, so there you go, you're already off to a bad start. But there are many people who have had sex that they know was not optimal contraception in that moment. And many of us got lucky in that setting and did not get pregnant that time. Many of my patients who are seeking abortion did happen to get pregnant in that time. 1 in 4 women in the United States will have had an abortion by the time they're 45 or by the time they reach menopause, and that's true internationally as well. Abortion cuts across many demographics. So people of all races, people of all religions have abortion. The thing that I take from this slide is that disproportionately people who are low income need abortion. 75% are poor or low income. And what resonates for me is that most people seeking abortion already have kids at home. When I have spoken with lawmakers who are not or others who are not supportive of access to abortion, they often repeat this false trope that it is young, irresponsible women who just don't want to use contraception who are having abortion. And I wonder where those people are seeking abortions, because they are not my patients. The people who I'm caring for often already have kids and are making a deliberate decision to invest the limited resources they have in parenting those children. And that's why or at least one of the reasons why they're having an abortion. The majority of abortion occurs very early in pregnancy. In fact, 2/3 occurs before 8 weeks, so very early in pregnancy. And 90% is in the first trimester. There are a number of abortions that occur above the first trimester as well. More frequently, those have different indications. So there's something that prevented someone from getting to abortion care earlier in their pregnancy, like the fact that their state banned abortion, or teens who didn't realize they were pregnant because they had irregular periods, people who receive a devastating diagnosis late in pregnancy about their own health or the health of the pregnancy and then decide to have an abortion. There are other people who need more time to make a decision about a pregnancy. Those cases are relatively rare compared to sort of the majority of abortions that we see. We've touched on many of these, but people seek abortions for all sorts of reasons. So unexpected pregnancy, a change in their life circumstances or relationship, a complication of pregnancy, issue with maternal health, and then an issue with fetal health. Obviously, the context in which I practice medicine has changed significantly in the past several years, and those changes have repercussions across all sorts of reproductive health care and healthcare in general. Those changes, I won't necessarily share this data, but are likely to shape where you decide to go to residency, regardless of whether you're going into OBGYN. Because of your access to medical care, perhaps, or the type of training that you want to have access to. It's too early to understand that data, but we already know that it's affecting the trends in terms of where people apply to and then matriculate to residency. The biggest change was access to abortion care and local access to abortion care. So the map on the top shows you the number of clinics in each state in May before the Dobbs decision. And you can see that every state, even if they only had a few abortion clinics, I know that it's small, but the legend is small, but that orange is at least 1 to 5 abortion clinics. And so a large part of the country was underserved, but at least had an abortion clinic. In December of 2022, you can see that there's a huge swath of black where there were 0 abortion clinics in those states. As you can imagine, there have been big changes in the number of abortions that are performed in states as a result of there being no clinics and no access. North Carolina is one of the states that had, particularly early on, the largest increase in abortion volume. And no one has done this statistic specifically, but if you think about, we have very few clinics relatively in North Carolina. And so the per capita, like per provider increase in abortion volume was quite high here. So in North Carolina, the number of abortions increased by about a third, but the absolute number increased a lot by the providers. And so we found that our clinics were oversubscribed. We had to extend clinic days, increase the number of clinic days that we had, recruit more providers, find new ways to care for patients, and find new ways to care for increasingly complicated patients who just had complicated stories as a result of having to travel across multiple states. Illinois has been the largest single increase, and Florida actually had a very large increase in volume. And Florida has just implemented on May 1st its 6-week ban. And so I'm not quite sure where those patients are going just yet, and I don't know. The thing is, even when you have anticipation, what I've learned over the past couple of years, and we've all learned, is that it takes time to increase our clinic volume and takes time to adjust. Interestingly, abortion volume actually has increased since the Dobbs decision. And so what does that show us? There was an outpouring of support and monetary support to increase access to abortion. And so some of the increased abortion probably was people who weren't able to get abortions in states that didn't have bans. So like in Illinois, it got easier to have an abortion and it got cheaper because there are funds that help you pay for abortion. Some of it is that there's enough funding that they can help people get to the abortions they need. I would say it's still a puzzle. Even in states that are banned states, overall the birth rate is dropping in the United States, and the birth rate seems to have dropped less in banned states. So people probably aren't accessing abortions that they otherwise would have wanted, but I think questions still out there as to whether people are getting the care that they need. I will tell you, I think it's really hard to imagine that people are able to get the care that they need from Texas, from Alabama, from Mississippi. It's just really hard to get yourself from one of those states to another state to get care, or takes a lot of know-how and courage to get pills sent to you if you're going to order pills online. However, a big change in abortion, particularly since in the last year, has been that states passed shield laws, so Massachusetts, New York, that allow their providers to prescribe abortion pills across state lines. In general, you can only care for patients in the state in which you are licensed, but this allowed Massachusetts providers to prescribe and send pills to people out of state. And so it's about 8,000 abortions per month of pills that are sent through these networks of telehealth. And then additionally, there are community networks where you can just buy pills without getting medical care. I may have time to come back to that, but that sounds like an unsafe thing, and it's actually, the evidence seems to show that it's really not unsafe, that people can safely manage abortion on their own. But it is really a change in the experience for individuals and the paradigm in terms of how people are getting the abortion care that they need. This is data from WeCount. So WeCount's this really cool project from the led by researchers in the Society of Family Planning, who contacted every abortion clinic that they could in the country and asked how many abortions they're doing each month. And you report via survey to them. And so they have 85% reporting and then are able to project the rest for how many abortions occur in each state in each month. So really amazing project. These are states in the South Atlantic subregion. You can see that at the top there, Florida was leading the charge in terms of providing abortion. North Carolina is, what color are we here? We're orange, so you can see, we took a little dip after North Carolina's law went into effect. We'll talk about that in a minute. But you can see overall our trend is increased. In What state is that crashed? Oh yeah, Georgia. So Georgia has a 6-week ban, right? And so you can see that there's a big drop after that 6-week ban. Interestingly, there's a big drop and then there's a creep up. So one of the things that abortion providers have seen is that people are presenting much earlier for care. So even with that 6-week ban, there's many, many people who come in and get very early abortion care. This one is always a gut punch. So these are banned states, and you can see that prior to Dobbs, they provided abortion, and after Dobbs, there's no access to abortion in those states. The other thing to just remember on this map is that Texas data is after Texas already had a 6-week ban. And so Texas is a huge populous state and was still providing over 3,000 abortions a month with a 6-week ban in place. And so that tanked too. This is harmful beyond sort of what we think of as induced abortion, right? Because it carries over to other types of medical care. Texas, because it was had the earliest ban, has some of the best evidence about what the effect was. And so in this study, they took conditions where people would present in the second trimester and have a medical indication for abortion. So when you present to the hospital with bleeding in the second trimester, preeclampsia in the second trimester, or you break your water in the second trimester, those are situations where the standard of care, the evidence-based standard of care, is to offer someone an abortion. They don't have to have it. They may wish to wait. However, the evidence-based standard of care is to offer them abortion, and in Texas, they were no longer allowed to do that. So they made the women wait to get sick. And shocker, when you wait for someone to get sick, they have more complications in the pregnancy. What they showed is that there was a doubling of severe morbidity among the individuals who were forced to wait as opposed to those who were able to intervene immediately. This is consistent with data from other states where people would just choose to wait because that's their, they weren't ready to move forward and they would choose to wait until they got sick. It's about a doubling of morbidity. So we know that early intervention is important. The other thing to know here is that it's a small sample, it's 28 people. Of the 28, 27 of 28, the fetus or baby died within 1 week. And that 27 of 28, it simply hadn't passed away by the time they published the paper. So these are situations where we're not expecting that the baby is going to live. All right, so the point of this exercise is to show you that where you train will affect now, if you were to train in OBGYN, but maybe other things too, how we provide medical care. Also how our patients receive it. So we're going to talk about the same case presentation. So this is a 32-year-old patient who presents with leaking of fluid. She's broken her water. The exam confirms rupture of membranes. Let's say she's 18 weeks. The ultrasound shows anhydramnios, so there's no fluid around the baby. And after discussing the risk to her pregnancy, she would like to proceed with the D&E. So she'd like to proceed with an abortion. It is as I just said, right, very low probability of fetal survival and risk to maternal health. So I trained in Oregon. When we had PPROM at 18 weeks in Oregon, the patient could receive immediate care. There was no nothing about it. You just offered them induction, you offered them an D&E, whatever the patient chose. If the patient were in Georgia, she can only have care if she's bleeding, infected, or if the heart rate stops. There are some centers, if she knew where to go or if she was referred to the right center, where they could put it before a committee. And the committee might decide that in 24 hours she could have care before she got sick, but it's not guaranteed and you have to go to the committee to make a decision. And they will often refer for patients for out of state. Contrast that with Idaho, where it's unlikely that the providers even mention abortion because they're worried about criminal penalties to themselves. And there are large maternity care deserts. There's been an exit of OBGYNs. If you're lucky, you're going to get helicoptered to Oregon. And if you're not lucky, they just wait for you to get sick. I didn't appreciate how much this affects training until I talked to one of my maternal fetal medicine colleagues, Allison Goulding, who is in, I guess I didn't keep her anonymous. She's in Houston, and she was saying that she was amazed that her interns thought that the appropriate management of this clinical situation was to call an ethics consult. That was the first thing that you did, as opposed to sort of the providing care for a patient. So it really does shape the way that we're training our residents, medical students, everything. Unfortunately, we know that abortion bans in general are associated with increased risk of maternal mortality. So states with abortion bans have 3 times the maternal mortality of states without abortion bans. And we estimate that that bans will increase the risk in those states disproportionately. Because of our sociodemographic distributions, because this is concentrated in the South, we also know that the bans will disproportionately adversely impact low-income individuals and people of color. The best data on what happens when people are denied abortion comes from the Turnaway study. If you remember one thing from today, I think one thing to think about that I would love for you to remember is that the way that you design a study is really important. And this is a really elegantly designed study. So what they did was they had 3 groups in the study. So they recruited people who were having a first trimester abortion. They recruited people who were presenting for care and were just under the gestational age limit at the care center in one of 30 places across the country, so they could get care. And then they recruited people who were over that limit and could not get care, and they followed them for 5 years. What they found was, this is in comparison to prior studies which had taken things like comparing people who had had an abortion to people who had had a miscarriage, right? That's not a reasonable comparison. Or people who had had an abortion to people who had a birth, or people who, right, you're not setting up, that's not apples to apples comparison, and so it's problematic. And so some of the older studies had concluded that abortion is detrimental to mental health, that it is associated with all these pregnancy complications. You really couldn't conclude that. And so what this study showed was that there's not, do I have another? Nope. That there are not adverse long-term mental health effects, and there's probably a slight benefit to mental health among people who are able to access abortion. That there are important economic and life consequences to being able to access abortion. So people are more likely to have economic success, to have 5-year aspirational plans. There are important social consequences. So people who are denied abortion are more likely to remain in an abusive relationship and continue to suffer intimate partner violence. On the medical side, continuing pregnancy, we know that pregnancy can be dangerous, right? And so continuing pregnancy, unsurprisingly, exposes you to pregnancy complications with delivery, right? 2 women in the small sample of people who were turnaways died. And I think it's 6% had pregnancy complications like severe preeclampsia. And so pretty, obviously there's health consequences with continuing pregnancy, which are people, if they decide to run the risk of those complications, is a big difference than people who were trying to decide not to run the risk of those complications, if that's really what you're focusing on. Okay, so North Carolina had a change in its laws, which was implemented in July 2023. So my lecture is even different this year than it was last year, although this slide is pretty similar. So we have a 72-hour waiting period, and the biggest change in the North Carolina law is that you now have to get in-person counseling prior to the 3-day waiting period before an abortion. And so whereas we were able to care for patients out of state who could get that counseling over the phone before, they now have to come in person and have that. And so it's really infeasible if you're traveling a longer distance, if you're coming from out of state, in particular, to take that extra time off work, to take a 4-day vacation to come to North Carolina to take some pills, right? We have to remember that when you are going for this type of medical care, right, if you're traveling across state lines, you gotta get childcare, you gotta get time off work, you have to maybe tell your employer if you're taking a 4-day break, you have to get transportation, you have to pay for the hotel. And so that has been a tremendous burden on our patients. When I also provide care in Virginia. When I care for patients in Virginia, I sometimes see patients from North Carolina who are under our gestational age limit here. And I have said to them, well, why am I seeing you in Virginia? Couldn't you have come and seen me in North Carolina? And what they say is, well, I'm a teacher. I can't take 3 days, I can't take an extra day off work. I'd rather drive the 5 hours than do it in 1 day. Or, imagine, right? I'm a medical student, right? I can't take 3 days off class to go and do that. And so it really meant that it decreased access for patients. The state-mandated counseling itself is punishing for providers and for patients. It takes longer to sign that. Maybe it doesn't take longer, but you sign in more places than I signed when I've gotten a mortgage. They have to sign every line after I read that component to them. So it's really, yeah, punishing for everyone. The biggest, so the 20-week ban is wrong. Sorry, we have a 12-week ban in North Carolina, except for some limited exemptions. Those are life-limiting fetal anomalies, emergent maternal health, and then we can go up to 20 weeks for rape and incest. The other change was that we no longer are allowed to care for patients who have a known or suspected diagnosis of Down syndrome. So we have to send all those patients, regardless of their gestational age, out of state. We have a telehealth ban, so we're not able to provide, even though we know it's safe, we can't provide medication abortion, for example, via telehealth. Teens have to have parental consent or judicial bypass to get care. And only medical doctors can provide care, so we can't allow advanced practice clinicians to provide care, even though we know that that's safe. The problem is that we know that the sorts of abortion restrictions which patients face in North Carolina and face much worse in our surrounding states don't decrease the rates of abortion. They increase the proportion of later abortion, they increase the proportion of unsafe abortion, and they exacerbate disparities in maternal health. So they don't really do what they're intended to do, and they cause harm. You don't have to believe me about this. The Institute of Medicine was probably a better name than the National Academy of Sciences, Engineering, and Medicine. I don't know that it makes it easier to understand, but basically they put together this panel of seasoned researchers who are not OBGYNs, who are not abortion advocates, just to review the data. And so these are the key recommendations. All right, questions about any of that? We're going to transition to the medical part.
With the 3-day waiting period and the 12-week ban, if you present like 2 days before the 12 weeks and you have that 3-day period, can you still get the abortion?
No. So yeah, I think that's a great point, right? So we can go up to 12 weeks and 6 days in North Carolina, but if you present at 12 weeks and 4 days, then you're out of it. And so that essentially is like an early and 12-week ban. And you may not get pregnant on a day that is, what if that 12 weeks and 2 days fell on a Sunday when the clinics are not open, right? Like, we can't control the physiology of when you get pregnant. So. Other questions about that? Okay. Oh.
For determining the time of the fetus's, the week span of the fetus, is that something that's you do an ultrasound to see where they are, or could a patient lie about when their most recent period was? Yeah.
So the determination of gestational duration is now so medication abortion, they do require that you do an ultrasound that corroborates the LMP if you're basing on LMP. Surgical abortion, we do an ultrasound too. So essentially it's going to be ultrasound determination, not LMP. Good question though.
Have you noticed that the 72-hour waiting period has any effect on patients at all in terms of their decision to proceed?
No. It has a lot of effects on people, but I don't think that it helps with their decision making. The counseling provided, the state-mandated counseling provided through the 72-hour counseling isn't medical. And so that's another frustrating thing, is that they have this visit where we're giving them misinformation or information that's not pertinent to their care, and then we have to restart the sort of counseling process. And there's other data to support that waiting periods don't change decisional certainty. One of the other things that came out of the Turnaway study was that 95% of people who were able to access abortion were happy that they were able to access, that they did not have regrets about it's a very high rate of satisfaction with that. Not directly to what you're saying, but. Okay, so The big point of this slide is that we use the same tools and same medications to treat induced abortion and miscarriage. So when we take away training in induced abortion, we also take away people's opportunity to really train to be skilled miscarriage providers, unfortunately. At less than 11 weeks, people have a choice. So they can choose to have a medication abortion or medical management of miscarriage, or they can have an aspiration abortion, which is a procedural abortion, not really surgical. When you say surgical, people think cutting, and we don't do cutting. Between 11 and 12 weeks, generally people would have an aspiration abortion. At 12 to 14 weeks, generally people have surgical abortions or procedural abortions, although we need to do some cervical preparation, which I'm going to show you in a moment. And then greater than 14 weeks, you do need cervical preparation, and people could choose to have a dilation and evacuation procedure, or they could choose to have a labor induction, so be in the hospital and get medicines to expel the pregnancy. The thing that will change on these slides next year is that the people are changing how late they're willing to provide medication abortion, and there's evidence accumulating that it is safe to have medical abortion later in pregnancy. And so I expect that there will be new regimens that, there are new regimens that are tested probably up to 13 weeks and 6 days, where people can have medication abortion even on their own at home. So what is a medication abortion? So we use a combination of medications. The first medication we use is mifepristone. That's a progesterone antagonist. And then on the second day, usually, people use misoprostol. We offer people some prophylactic medications. So we actually don't use antibiotics anymore, which is why it's starred. But historically, antibiotics have been provided for prophylaxis. We do provide pain medications, generally ibuprofen, and then antiemetics because the misoprostol causes nausea. There are a few contraindications to medication abortion. So porphyria or chronic steroid use, coagulopathy or clinically significant anemia, and inability to follow up or access emergency care. I'm going to take a moment to say that one of the pieces that makes self-managed abortion safe is that people are good at determining their gestational age based on their LMP, and people can determine whether they have a contraindication. So we have good evidence to show that they can do both those steps, which are what you need to do to determine whether medication abortion might be safe for you. Mifepristone binds progesterone receptors, and it's a competitive antagonist, and so it has affinity greater than progesterone, but it doesn't activate the receptor. And it's an antiprogestin, so it causes a couple different effects. It causes decidual necrosis, it causes separation of the trophoblast cells from the decidua basalis, it induces uterine contractility, it decreases HCG secretion into the maternal system, and it softens the cervix. So I think of it sort of as a prep stage, right? It prepares the uterus to expel the pregnancy. Mifepristone has been in the news and in the courts recently because of this, the challenge to mifepristone's approval in Texas, and a judge actually questioned the original approval of mifepristone in 2000. That was so scientifically absurd because there are over 100 studies which show that mifepristone is very safe with over 120,000 patients. And so we know that it's a very safe drug. It's probably safer than Tylenol or ibuprofen, but was called into question because of an opposition to the effects of it, not really a question of its safety or efficacy that was legitimate. Progesterone is pro-gestation, and so it maintains the pregnancy, it decreases myometrial excitability, and the withdrawal results in uterine contractions. All right, so then the other component of the medication abortion is misoprostol, and this is a synthetic prostaglandin. We use it in other contexts in OBGYN, so you may see it used when you're on labor and delivery as an agent in lower doses to help with inductions. It was actually developed for prevention of gastric ulcers, and it's absorbed through mucous membrane. So we generally use it buccal or vaginal for medication abortion. It has lower peaks with oral use. And yeah, we don't use it rectally in that setting. But we do use it in that to stop bleeding with obstetric hemorrhage. It is a uterotonic, and it helps with cervical priming and softening. So what's it like to have a medication abortion? It's really helpful when we talk through medication abortion with patients to use visual aids. And so when I work at Planned Parenthood, at least, we hand out these visual aids to help with patients. And what we tell people is that after the mifepristone, they'll have light bleeding, maybe a little bit of nausea, but generally pretty stable. After the misoprostol, they should expect heavy bleeding. And in general, that heavy bleeding is more vaginal bleeding than we would tolerate at other times, so up to filling up 2 pads in an hour. However, that bleeding should be confined to like a 4 to 6 hour period, so it's a pretty short period. They have some cramping, they may have some nausea and discomfort. And then they have 2 to 4 weeks of bleeding, more like a period. Surgical abortion has 2 steps, so cervical preparation and then evacuation. Earlier in pregnancy, we can do cervical preparation just with mechanical dilation. So on the top right, those are dilators, and we progressively dilate the cervix. So we stretch it out a little bit more, a little bit more, a little bit more. Yeah, I'll show that in a second. If the patient is over 12 weeks and really over 14 weeks, then we have to think about what other tools we can use to help soften the cervix and make that dilation less painful and make it less likely that with the pressure that we're putting in that we perforate the uterus, which is one of the rare complications, but a complication. So we can use misoprostol for cervical ripening. We also use these seaweed sticks, which are called laminaria, and they're osmotic dilators, so you insert them in the cervix, and then they absorb moisture from the cervix and the vagina and slowly expand. Usually we'll leave them for up to 24 hours to open up the cervix and make the procedure safer. That mechanical dilation of those osmotic dilators also causes the body to release prostaglandin, so sort of have that misoprostol effect. And then there's the evacuation step. So in the top right, that's a manual vacuum aspirator. So that little syringe allows us to empty the uterus in many, many circumstances. We, in practice, use that probably up to about 9 weeks gestation, but it can be used for later gestations as well. You just have to empty it more. The cervix is really convenient, and the uterus is really convenient in that the number of weeks of gestation is equal to the number of millimeters of cannula that you use. So if I'm emptying a uterus with an 8-week gestation, magically I use an 8-millimeter cannula. I've always been surprised about why that would possibly work, and I don't have an answer for you. If we don't use that manual vacuum aspirator, then we can use a machine like that, which works the same. It just is a constant suction. It takes a larger volume and makes a rumbly noise that sounds like a vacuum, and some patients don't like. People generally choose a dilation evacuation if they have the option over a labor induction abortion. Abortion's really safe. So uterine perforation occurs about 1 in 1,000 times. Hemorrhage is around a 1% or 1% risk at less than 15 weeks, and around a 2% risk at greater than 17 weeks. Retained products of conception is quite rare. Infection is relatively rare. We do use prophylactic antibiotics when we do perform surgical abortion. And then post-abortal hematometra or having blood trapped in the uterus is a relatively rare circumstance as well. Abortion is in fact safer than many of the things that you've already done today. So safer than driving a car, safer than a colonoscopy. I have talked with the North Carolina legislators about whether they want a 72-hour waiting period for using a tampon, but there haven't been any takers. And it is you're about 14 times more likely to die giving birth than you are having a first trimester abortion. I've talked about self-managed abortion. So the first step, again, is determining that you're a candidate for a medication abortion. The second step is, can you take the abortion pills and follow the instructions? And evidence shows that people can do that. And then the third step is determining whether you are not pregnant, and people can determine that they're not pregnant. And that's why we know that self-managed abortion is something that's safe. I would technically not call it self-managed abortion if you were to order pills from one of the abortion services in another state. This is a link to Plan C, which doesn't actually sell abortion pills, but helps people access abortion through a bunch of different means. No state has a law currently on the books that makes self-managed abortion illegal, and no state requires reporting of suspected self-managed abortion. And so when we think about self-managed abortion, I think it's important wherever you go and whatever you go into to have sort of a harm reduction mentality, right? We are accustomed to other circumstances in medicine where we do not call the police when someone has done something that is illegal, IV drug use, people who are unauthorized immigrants. We're not calling the police about that. There are reporting requirements. So in North Carolina, if you gather the information that the person bought pills online and they're having a complication, then you actually do have to report that they got the pills online, but that's not telling the police, that's telling the Department of Health and Human Services. And so this is to provide reassurance to people about how we practice medicine and what our obligation is to the patients, and also to keep ourselves safe. Another thing I will note is North Carolina does have a law that we can't advertise, that we are not allowed to advertise self-managed abortion. That you shouldn't, I don't post on my social media this as QR code to Plan C. I would discourage you from doing so as well for that reason. This is a great piece in the New England Journal of Medicine about the sort of ethics in the emergency department of how to treat patients who may be self-managing abortion. Our group recently encountered, there's a provider in a neighboring state who had a patient who had a miscarriage in the second trimester, and someone called the police from the emergency department because she delivered on the side of the road, and they called it fetal, abuse of the corpse in the way that they transported it to the hospital, and so the person was charged. Unfortunately, we know that disproportionately those who have reports of self-managing abortion are penalized, again, are gonna be people of color. And so I think our ethical obligation is really to the patient in this situation. We were in the midst of a very sad time the last time I gave this lecture, and I think it's a less sad time now. These disappointing affirmations are very helpful. And so we posted this in the workroom in our new abortion clinic on 4200. We had to move, as part of the new North Carolina law, we were no longer able to provide abortions in the setting in which the outpatient setting we had done so for many, many years, and had to move to an inpatient setting to be able to provide care. This was helpful for us. You all will be in the Duke community for many years, and I would invite you to join the DREAM team. My colleague and boss, Dr. Gray, started the DREAM team, which is a group of now over 160 people from across the health system who meet monthly, get updates from our state and federal lobbyists of the Duke system about things that are happening on the state and federal level. We talk about various sorts of advocacy issues, not restricted to abortion care, and talk about opportunities to advocate. We meet with legislators, so in the top left, the green box is around David Price, who is our former congressman from this district. In the bottom, or I guess, the bottom frame there in green is Representative Von Hafen, who's in the state legislature and is a big advocate for reproductive health. We also got to meet with Admiral Rachel Levine, I believe, who is the second in command at the Federal Public Health Service Corps, is that right? I don't know, Dream Team's been great. It's a great way to express your angst and know what's going on. If you wanted to join, email Caroline Oviedo. You also can write op-eds, contact your legislators, register to vote, register patients to vote, and this is a way to find your North Carolina legislators. It can feel like it doesn't matter to talk to my legislator, and this is this is a situation where it really does, and they appreciate it. And probably if you live in this area, your legislator is a supporter for you, a supporter of many of the things that you're a supporter of. However, they also really benefit from hearing stories. And so if you want to share an anonymized patient story that doesn't violate HIPAA, but say, this is something that I saw that really impacted my patient, and this is how this policy impacted my patient, or say, thank you for supporting this, it's a place you can do that. All right, so 5 minutes early, but abortion is common. Abortion is safe. We talked about methods for induced abortion, which include medication abortion and surgical abortion. Oh, yeah, and that's it. Yeah, questions? Go ahead.
As an abortion provider, can you talk to how closely you might work with lawyers, and when you have new laws that are put into place, how do you go about learning the logistics and like knowing what care you can provide?
You don't have a law degree? I got one before. It's a great question. So yes, we work with lawyers a lot. So I have 3 sets of lawyers. We have the hospital counsel, we have an independent criminal attorney, and then we work with lawyers from the ACLU. And so there's many lawyers within those sets as well. When it happened that the process varies by institution in terms of how you understand what the new laws mean. In some places, you will work directly with the lawyers to sort of say, all right, what's the care you provide? What do you think this means? Part of the problem with the laws is it's not as though they're medically oriented. They're not supposed to be, right? So they say things that don't have medical terminology. So you can define medical emergency in a bunch of different ways, and probably maybe not the way that they define it in the law. That doesn't translate to, is this situation one? And so you work on the spectrum of risk and decide what the risk you're willing to take is and what the institution is willing to take. And then you check with another lawyer about what your criminal liability is as a result of that. One thing I forgot to say, so the reason that so it's a hard type of medicine to practice, but it's also a really rewarding part. I don't know of another type of medicine where you spend 5 minutes with the patient and can change their trajectory and get to do that with someone and so quickly in such a short interaction, and really can change their life and have people be grateful in a positive way. And maybe plastic surgery, but I don't think that there's 5-minute interactions in plastic surgery. And so I would say, even though it is hard, it is usually worth it.
I'm sure you already explained this, but I guess I was a little confused. And so in the states that have abortion ban, does that also apply to like miscarriage, spontaneous abortions?
So no, oftentimes they have exceptions for miscarriage and exceptions for ectopic, but the way that they define abortion may not allow you to treat those conditions. And so sometimes when it's hard to diagnose a miscarriage actually, and there are fringe cases. And so what you end up doing is making patients wait additional time so that you can confirm that diagnosis of miscarriage, as opposed to expeditiously treating, for example. In Tennessee, they've now repaired this, but in Tennessee, when their law went into effect, it just said pregnancy. It didn't say pregnancy within the uterus. And so they actually couldn't intervene in ectopic pregnancies immediately until the patient was actively hemorrhaging on death's door. And so in some centers, they were caring for them. In some centers, they were looking for transfers to intervene before the patient got sick. The other problem with miscarriage is that we use mifepristone for miscarriage, and misoprostol for miscarriage, just like we would for abortion. In North Carolina, we've gotten pushback from pharmacies. So pharmacies will call us and say, for our miscarriage patients, will say that they won't give them misoprostol because they can't confirm that I was there to administer the first medicine, and they don't know what it's being used for. Walmart was awful for a while. Across the state, they had provided misinformation to their pharmacists. So it wasn't the individual pharmacist. They were following company policy and wouldn't give misoprostol to any of our patients. And that affects miscarriage care, right? So it's these carryover effects. The other problem long-term is that we learn as OBGYNs to empty a uterus medically or with procedurally, and the way you do that is basically the same with a miscarriage and an abortion. And so if you have OBGYNs out there who are only seeing few miscarriages, whereas they might have seen more patients for abortion, then they are less skilled at that care.
This is more of like a law-related question, but if someone were to try to induce abortion like at home using like non-medical procedures, can they be like charged for like trying to disrupt the pregnancy?
Not in North Carolina. There's not a penalty for self-managed abortion. I think that would be a circumstance. So when we talk to our colleagues in the emergency department or well, mostly in the emergency department about like what do they need to write in the chart, one of the things we talk about is you don't really need to write where the pills came from if that's what they're doing, or like you can just say someone is pregnant and bleeding. You don't need to inquire about or get into the circumstances. However, if someone introduces something into the vagina or cervix to induce abortion, that is something that we need to know about because there's different risks than taking abortion pills that you purchase online, if that makes sense.
Yeah, that's more what I was referring to. So if someone like has a complication because they introduce something like into the uterus and they come in for like medical care, do they have to be like reported?
Not yet. And nowhere that I'm aware, actually that's not true. So in South Carolina, it is illegal to self-manage abortion in that way. The pills are still paralegal, but yeah. But I don't know what the reporting requirement is.
How much does insurance cover, if anything, for non-medically indicated abortions?
Great question. So if you have Duke Basic or Duke Select, it has excellent coverage for abortion. Medicaid does not cover abortion federally, except for in cases of rape, incest, or imminent threat to maternal health. Half of births are through Medicaid, so you can imagine that's at least half of patients. And the numbers I shared on 75% of patients seeking abortion are low income means that it's probably more who would otherwise use Medicaid. Private insurance in North Carolina has pretty poor coverage of abortion. The state employee health plan is not allowed to cover abortion, and plans purchased through Obamacare are not allowed to cover abortion. So great point. That is a huge cost, a huge barrier for our patient. A clinic abortion is around $500. A medication abortion is around $500. Pills online are less expensive than that. And if you need second trimester care in the operating room, it's somewhere from $3,500 to $11,000, depending on where you are. Right? I mean, if you went and said, how much is my appendectomy going to cost? I have no idea how much your appendectomy is going to cost. It happens that we have a package price. I can tell you how much a second trimester abortion costs here, but right, medical costs are very hard, and so depending on where you are, they may not have that.
Going off that question, does Duke interact with the abortion funds, like the Carolina Abortion Fund?
Yes.
Okay, so patients don't have to go to Planned Parenthood if they need those funds?
Correct.
Okay.
Yeah, we are able to take those funds. I'm over time. I appreciate you guys being here and attentive. There's a lunch. Where is the lunch? There's a lunch here in the learning hall, 12 to 1. Happy to answer more questions there. Thanks.